for the delay in starting the presentation. There were some issues with my mic, and still I'm trying to figure it out. That's why I'm on the phone. I hope you all could hear me, but and also see the PowerPoint on the screen. So I will be talking on the anatomy. The topic was actually anatomy relevant to swallowing with regard to the pharynx. But when you discuss about anything about deglutition or swallowing, you need to know a little bit of the oral cavity and the esophagus, considering that the pharynx is the middle part structure which connects these two in the process of swallowing. So I will very briefly talk about the structures of the oral cavity and also the structures of the esophagus, anatomy of the esophagus, which is involved in swallowing, and I will go in detail about the pharynx. So to start with, hold on, hopefully this works. Yeah, so great. So a normal swallow basically requires coordination of 3 anatomically and functionally separate aerodigestive tract structures, which comprises of these following: the oral cavity, the pharynx, larynx, and all are the main things in the upper aerodigestive tract. So we'll start off with the oral cavity, but we have to keep in mind, along with these 3 structures, more than 30 muscles act as a hydrodynamic pump with different valves, allowing the food and the liquid to be transferred safely into the stomach without it entering into the respiratory tract. So the first few structures within the oral cavity we'll be discussing will be the lips, the buccal mucosa, and the teeth and the jaws. The lip, you can see it is very important because it's the first structure we use when we actually try to take in the food or suck some liquid into the mouth. And the lip helps in preventing drooling or dribbling of the food. So we need to have adequate closure of the lip to help start the act of swallowing, chewing and swallowing. So the main muscle involved in the lip is the orbicularis oris muscle. It encircles the opening of the mouth, and that's the closure of the lips when it activated causes the complete closure and sealing of the mouth. So it acts like a seal. And very full activation of this muscle will cause it also to purse the lip. Like sometimes you see taking selfies in pictures, you see really people tense the lip to cause a pursing of the lip. The fibers of the other muscles, the different perioral muscles around the orbicularis oris, blend within the orbicularis oris, and it inserts into a central tendinous structure lateral to the lip called the modulus, which you can see here. So this is the orbicularis oris, and these are the different other perioral muscles which connect to the orbicularis oris. And this area here is called the modulus, which is a tendinous structure. Now, the upper lip, the muscles of the upper lip include the zygomaticus major, the zygomaticus minor muscle, the levator labiae superialis muscle, and the levator labiae superialis alicae nasalis muscle, and the levator angli oris muscle. Now, these muscles are quite a mouthful, and all these muscles are supplied by the facial nerve. And most of these muscles are muscles of the face, but they also help in elevating the upper lip, pulling the upper lip, and also pulling the corner of the mouth upwards. And the zygomaticus muscles have the diagonal action to pull the sides of the lip. Coming to the lower lip, the muscles of the lower lip include the depressor labiae inferioris and the depressor angli oris, and these muscles help in pulling the lower lip downwards and the corner of the mouth downwards. So all these muscles also help in the adequate functioning of the orbicularis oris to receive the food into the mouth. You can see here the upper and the lower lip in a sagittal view, and the lip is usually supported by the mandible and the maxilla, the teeth from the mandible maxilla, which help in preventing the lip from falling backwards, thus creating an adequate seal. So loss of teeth, the patient may not have an adequate seal. Coming to the cheek, this is the lateralmost part of the oral cavity, and the main muscle in the cheek is the buccinator muscle, It is relatively a broad muscle, and it is usually activated when you try blowing the cheek. It's also supplied by the facial nerve. It originates from the pterygomandibular raphe and also the bony surfaces of the maxilla and the mandible. Its fibers also blend into the orbicularis oris, thus creating the vestibule of the oral cavity. So this is the a picture of illustration of the buccinator muscle, and you can see the other muscles of the upper lip blending into the modulus. Here is a cadaveric video of the orbicularis muscle and the buccinator muscle, and you can see what I was saying, that they all work together when we open the mouth and to receive the food. And you can see that the attachments of the buccinator in the inferior part of the mandible and also the upper part of the maxilla, and medially it kind of blends into the pterygomandibular raphe. Posterior to this starts the superior constrictor muscle. These are the other muscles, all the zygomaticus minor, major, and the levator and depressor muscles coming and blending into the orbicularis oris. Now, if you see the oral cavity as such proper, it contains inferiorly the tongue, superiorly the palate, and laterally the upper and lower jaw with the corresponding teeth. And these, the bony portions, the maxilla and the mandible, provide support to the muscles of the oral cavity, thus helping the patient to chew and grind the food. And this video, you can see the occlusive position of the teeth in relation to the upper and lower jaw. This position of the teeth helps in such a way that the food could be bit, chewed, and grind into a bolus and then swallowed. Now, a small note on the importance of the mandible. The mandible is a strong bicortical bone, and it is there are a lot of muscles which are attached to the mandible, which I'll be elaborating. But the importance of the mandible is that it has a joint, and it's called the temporomandibular joint, and it is a synovial joint with a capsule, and this joint helps in opening and closing of the mandible. The muscles which are attached to the mandible are generally termed as the muscles of mastication, and there's mainly four muscles: the temporalis muscle, the masseter, the lateral, and the medial pterygoid muscles. This slide shows the origin insertion of the different muscles, but I thought it better depicted when I showed through a video. And you can see this is a cadaveric video of the masseter muscle. It arises from the lower border of the inner surface of the zygomatic arch, which is the zygomatic arch of the skull, the inner surface, and it inserts into the ramus of the mandible, which is over here. And the nerve supply for this muscle is the anterior division of the mandibular nerve, which is the fifth cranial nerve, the trigeminal nerve. The masseter muscle helps in elevation of the mandible, the protrusion of the mandible, and the side-to-side movement of the mandible. The next muscle is the temporalis muscle, and this arises from the floor of the temporal fossa and the deep surface of the temporalis fascia. It condenses down to form a small tendon, and that tendon passes deep to the zygomatic arch and gets inserted into the coronoid process of the mandible, and it's also supplied by the anterior division of the mandible nerve. This temporalis muscle elevates the mandible and also helps in retracting the mandible backwards, but it does not help in protrusion of the mandible. Coming to the pterygoids, the lateral pterygoid has two heads. The upper head arises from the infratemporal surface of the greater wing of the sphenoid, and the lower head arises from the lateral pterygoid plate, lateral surface of the pterygoid plate, and it inserts into the pterygoid fovea and also in the neck of the mandible in front of the capsule. And it's also supplied by the anterior division of the mandibular nerve. It helps in pulling the condylar process forward, and that's why the mandible, it can depress the mandible, helps in protrusion of the mandible and also side-to-side movement, but it does not, the lateral pterygoid does not elevate the mandible. The medial pterygoid muscle, it has two heads, the superficial head and the deep head. The superficial arises from the tuberosity of the maxilla, and the deep head arises from the medial surface of the lateral pterygoid plate, and they insert into the medial surface of the ramus of the mandible. And this has a different branch of the mandible nerve. It does not the muscle is not supplied by any branch of the mandible nerve rather than actually the trunk of the mandible nerve. And it helps in elevation of the mandible, protrusion of the mandible, and side-to-side movement of the mandible. The muscles of mastication, all these muscles exert enormous force, and they're required to break down the food into particles. And they also help in moving the mandible quickly and precisely in rapid succession to help with chewing and also making the food into a paste. Now we go to the next part of the PowerPoint. Coming to next, one of the most important structures in the oral cavity and the oropharynx is the tongue. It's a mobile muscular structure on the floor of the oral cavity, and partly it lies in the oral cavity and the posterior part lies in the oropharynx. It is attached by its muscles to the hyoid bone, mandible, styloid process, soft palate, and the pharyngeal wall. So it has multiple attachments for it to actually anchor itself and move. The tongue is actually a muscle composed of different muscles. So it is the organ for swallowing, taste, and speech. And you can see here that it contains extrinsic and intrinsic muscles. So there is a connective tissue septum in the middle of the tongue, and it divides the tongue into two halves. And each half contains its own pad, extrinsic and intrinsic muscles. And posterior to the tongue is the vallicula, and between the vallicula and the anterior part of the tongue is the circumvallate papillae, and posterior to the circumvallate papillae is the base of the tongue. So this circumvallate papillae is the this circumvallate papillae divides the tongue into the anterior and the posterior or base of tongue. The vallicula is bounded by the median and lateral glossoepiglottic fold, and it continues with the larynx. So again, the muscles of the tongue, the intrinsic muscles and the extrinsic muscles of the tongue. The extrinsic muscles help in protruding, retracting, depressing, and elevating the tongue, all the gross movements, while the intrinsic muscles help in the finer movements of the tongue during mastication and swallowing. They alter the shape of the tongue by lengthening the tongue, by shortening it, curling it, or sometimes uncurling its tip, and also the sides and flattening. So you need these muscles to try to get the bit of food bolus which is stuck on the side of the vestibule of the mouth, or also in the lower part of the portion of the mouth. A bit more in detail about the intrinsic muscles of the tongue. The intrinsic muscle fibers, there are totally 4 muscles, main muscles: the superior longitudinal and the inferior longitudinal, the transverse and the vertical muscles. Now, all these muscles are confined to the tongue and not attached to any bone. That means they originate from the tongue and they insert within the substance of the tongue itself. So there's no attachment, no bony attachment. So, and the superior longitudinal muscle, it is a thin layer which is deep to this mucous membrane, and it's situated in the dorsum of the tongue. And it originates from this fibrous layer from the medium fibrous septum, and then it inserts along the margins of the tongue into the mucous membrane. It helps in elevating the tongue tip and the lateral border, and also helps in shortening the tongue. The inferior longitudinal muscle, that is over here, much lower, it is close to the inferior surface of the tongue, and it originates from the root of the tongue and also the body of the hyoid bone. That's where the tongue is attached, and the tongue muscles are attached, and it inserts into the tip of the tongue or the apex of the tongue. This intrinsic inferior longitudinal muscle helps in depressing the tongue tip down and also helps in shortening the tongue. So then the transverse muscle, this lies deep to this superior longitudinal muscle, and it's transverse as the name implies. It arises from the medial fibrous septum and inserts into the fibrous tissue in the lateral lingual margin. It helps in elongating and narrowing the tongue. And I think this is the tongue we use for licking an ice cream or licking something off a spoon. And the verticalis muscle, these fibers, you can see it right here. Sorry, my verticalis muscle, and these intersect the transverse muscle and originate from the submucous fibrosis layer on the dorsum of the tongue, and inserts into inferior borders of the tongue, lower part of the tongue. This helps in widening and flattening of the tongue. This muscle is more pronounced when you're actually trying to receive some food into the mouth. Coming to the extrinsic muscles of the tongue, these muscles, as I mentioned, they have gross movements. So the first important muscle is the Genioglossus muscle. It is a fan-shaped muscle, and it constitutes the main bulk of the tongue. You can see over here. It originates from a small tendon, which is attached to the mental spine of the mandible, or the glenoid tubercle, and it inserts entirely into the dorsum of the tongue as it spreads out. The lower parts of it also, and sometimes inserts into the body of the hyoid bone. This helps in protruding the tongue and also depressing the central part of the tongue. The Hyoglossus muscle is a thin quadrilateral muscle, and it originates from the greater horn of the hyoid bone and inserts into the inferior aspect of the lateral part of the tongue. It is the most superficial muscle of the tongue and helps in retruding and depressing the tongue. The next muscle is the Styloglossus muscle. It is a small, short triangular muscle. It originates from the anterior border of the styloid process and the stylohyoid ligament, and it inserts into the side of the tongue posteriorly, and it also blends into the Hyoglossus muscle. This also helps in retracting, but it also helps in elevating the tongue. The palatoglossus, or this muscle forms the posterior pillar of the tonsil. It is a crescentric or a narrow, thin crescentic shaped muscle. It's a part of a soft palate, and it is supplied by the pharyngeal branch of the vagus nerve. Now, if you actually come to the nerve supply, which I'll come to the next slide. Okay, I'll tell you the nerve supply in the next slide. But this is a cadaveric video of all the different muscles which I described now. You can see this is the tongue as a whole, along with the oral tongue and the base of the tongue. The lower part of the tongue is connected to the hyoid bone and also the mandible. And you can see this fan-shaped muscle here is the genioglossus. It comes from the mental spine tubercle and it fans out into the inferior surface of the dorsum of the tongue. You can see the geniotubercle of the mandible over here, and you can see this muscle fans out almost the entirety of the tongue, and it helps in protruding the tongue and also depressing the central part of the tongue. And there are two on either side. And the next muscle is the Hyoglossus muscle. This is a more superficial muscle of the tongue. It's quadrilateral in shape. It's attached, so hyoglossal, so it's attached to the hyoid bone and then into the substance of the tongue. And over here is the remnant of the styloglossal. One part is usually arises from the styloid process and it inserts the tongue. And here is the lateral floor of mouth, the part where the tongue and the geniohyoid and mylohyoid muscle come together. So one important point to keep in mind, especially for exam purposes, is the nerve supply of the tongue. All the extrinsic muscles and the intrinsic muscle are supplied by the hypoglossal nerve, except the palatoglossus muscle, which is supplied by the pharyngeal plexus, or which is the pharyngeal branch of the vagus nerve. For the sensory innervation, The anterior two-thirds of the tongue is supplied by the lingual and lingual nerve, which carries the pain and temperature sensation. These are the general sensations where you can feel the food bolus, or you can feel the temperature, extremes of temperature. And the lingual nerve is joined by the chorda tympani, which is a branch of the facial nerve. The chorda tympani carries the taste on either side of the tongue, taste sensation. The posterior one-third of the tongue is supplied by the branches of the glossopharyngeal nerve and the glossopharyngeal plexus, and which carries all the three sensations. The vallicula, like similar to the larynx, it's supplied by the internal laryngeal branch of vagus. This is a anatomy video of the tongue in relation. Oh, this is a cadaver anatomy video of the tongue in relation to the floor of mouth. You can see the mucosa of the tongue continues down into the floor of mouth and into the lower jaw, and the central fibrous band in the central part of the tongue at the dorsum is the frenulum, and at this juncture lower down you have the sublingual and submandibular duct openings. And posteriorly, here is the base of the tongue, posterior to the circumvallate papillae and a foramen cecum. Now we finish the tongue. The tongue actually rests on the floor of the mouth and the hyoid. So we will talk about the muscles of the floor of the mouth and the suprahyoid muscles. The main muscle of the floor of the mouth is the mylohyoid muscle, which is again a fan-shaped muscle, which stretches along the inferior part of the mandible, and the other muscle is the hyoglossus muscle. So here is to talk about the any of the muscles is attached to the hyoid bone. You need to understand the hyoid bone as such. Once you have a good understanding about the hyoid bone, it will be easy to know the different attachments of the muscles to the hyoid. The hyoid bone as such is a horseshoe-shaped bone, and it's situated in the anterior or middle part of the neck, between the mandible and the thyroid cartilage. It is the only bone which is suspended by muscles and ligaments, and not attached to any particular joint, and the helps in elevating the larynx and the pharynx upwards. So it is lower part of the hyoid is attached is connected to the larynx by the thyrohyoid membrane, and the upper part of the hyoid bone is composed of the suprahyoid muscles. So here is another illustration of the hyoid bone. It has two horns, the lesser horn of the cornu and the lesser horn and the greater horn. And on the right side, you can see the different muscles which are attached to the hyoid bone. This is a table which depicts all the suprahyoid muscles. You can see the digastric, the two anterior and posterior of the digastric bellies of the digastric muscle, the stylohyoid muscle, mylohyoid, geniohyoid, and the hyoglossus. All these are attached to the hyoid bone. The hyoglossus gets its origin from the hyoid bone, whereas the other muscles are inserted into the hyoid bone. And these muscles help in elevating the hyoid during the swallowing, helps in drawing the hyoid bone forward and also upwards. These suprahyoid muscles also function to help in mastication and also opening the opening the mandible. So we can call them also as jaw opening muscles. The mainly anterior belly of digastric, posterior belly, lateral mylohyoid, and geniohyoid. This is a video of the suprahyoid muscles. You can see the mylohyoid muscle. It is the origin is from the mylohyoid groove of the mandible in the inner surface of the mandible. It forms a sling, and the inferior part is attached to the hyoid bone. And the mylohyoid nerve supplies the nerve to mylohyoid, which is a branch of the mandibular nerve or trigeminal, which is further a branch of trigeminal nerve. Then you have the geniohyoid muscle. It arises from the inferior mental spine and the inserts into the hyoid bone. supplied by the hypoglossal nerve. It helps in drawing the hyoid bone forward and upward. And then you have the styloid, arises from the styloid process, and that attaches to the hyoid bone. It's supplied by the facial nerve, helps in elevating the hyoid. Then you have the digastric muscle, the anterior and posterior belly. The posterior belly arises from the digastric fossa of the mandible, which is over here, and it inserts into the hyoid bone through an intermediate tendon. And this part is supplied by the facial nerve. And my apologies, the posterior belly is from the mastoid notch of the temple bone, and the anterior belly is from the digastric fossa of the mandible. And the anterior belly is supplied by the nerve by the trigeminal nerve, and helps in elevating the head. So posterior belly, digastric notch of the temple bone or mastoid notch, inserts into the hyoid bone, nerve supplies facial nerve. The anterior belly is the intermediate tendon, originates from the intermediate tendon and inserts in the digastric fossa of the mandible, and supplied by the nerve supply nerve to the mylohyoid muscle. Coming to the oropharynx, the oropharynx includes the posterior 1/3 of the tongue with the lingual tonsil, the palatine tonsils, soft palate, and the superior constrictor muscles. The anterior palatoglossal arch and the palatopharyngeal arch are present in the lateral oropharyngeal wall. And the tonsillar bed, you can see the palatine tonsils here, and this is a picture without the tonsil. The lateral wall of the oropharynx is formed by these three structures: the tonsillar bed, the palatopharyngeus, and the palatoglossus. And the lateral to this is the superior constrictor. The inferior border of the oropharynx is demarcated by the tip of the epiglottis, and the sensation is through the pharyngeal plexus, which contain the branches of the vagus and the glossopharyngeal nerve. Here you can see the sagittal view of the palatopharyngeus and the palatoglossus and the palatopharyngeus muscle, and its insertion into the palatine aponeurosis. In this axial view, you can see the extent of the superior constrictor muscle, which is lateral to the tonsillar bed, and it envelopes the whole of the oropharynx from one end to the other end. And there's another picture depicting the superior constrictor muscle over here, forming the lateral wall of the oropharynx. And both the superior constrictor joining each other at the median raphe. Now, if you actually see the posterior pharyngeal wall, of the oropharynx or a pharynx generally, it's composed of 4 layers. If you see from inside out or from anterior to posterior, you have the mucous membrane, the pharyngo-basilar fascia, the muscular layer, which composes the constrictor muscles, the buccopharyngeal fascia. And beyond this is the retropharyngeal space, the prevertebral fascia, and also the longitudinal ligaments and the vertebral bodies over here. So all this compose of the posterior wall of the oropharynx. Coming to the palate is bounded in front and at the sides by tooth-bearing alveolus of the upper jaw. The palatine aponeurosis over here is basically a flatten tensor palatine muscle which splits in the midline to enclose this musculus uvulae, which is actually hanging in the midline in the posterior part of the palate. And this basically, the importance of palate is that the soft palate elevation comes in contact with the pursuant ridge or the small ridge in the posterior pharyngeal wall, closing this pharyngeal isthmus during swallowing. And this prevents regurgitation of the food bolus or liquids through the nose. The palate as such, the hard palate is formed by the palatine process of the maxilla and the palatine bone, which forms a part of the oral cavity. And the soft palate, it separates, it's a part of the oropharynx, and the inferior part is the oropharynx, and the superior part forms the nasopharynx. And laterally, you can see the soft palate is continuous with the palatoglossus and the palatopharyngeal fold, and this joins the tongue and the pharyngeal wall, respectively. And the general sensation of the palate is mostly by the branches of the trigeminal nerve, which is the maxillary nerve, and from the posterior part of the palate, it is by the glossopharyngeal nerve and the plexus around the tonsil. The muscles of the palatine aponeurosis are levator veli palatini. This is, you can see here in the cut muscle. It originates from the cartilage of the eustachian tube and the petrous part of temporal bone and inserts into the palatine aponeurosis over here. And the supplied by the pharyngeal plexus, it helps in elevating the soft palate beyond the neutral position, thereby occluding the pharyngeal isthmus. The tensor veli palatini, this is the next large muscle. It originates from the scaphoid fossa of the medial pterygoid plate and also the spine of the sphenoid bone, and also a part of it from the cartilage of the eustachian tube. It inserts into the palatine aponeurosis, and it is also supplied by the branch of the mandibular nerve called the median pterygoid nerve. It helps in stiffening the soft palate and also helping in opening the eustachian tube. The palatoglossus and palatopharyngeus are the other muscles which I already dealt with. And of course, musculus uvulae, which is the muscle which originates in the middle of the soft palate. It arises from the posterior nasal spine and inserts into the mucosa of the uvula. And it's also supplied by the pharyngeal plexus. And it helps in retraction and elevation of the uvula, and also thickening of the central region of the soft palate. Now, why is the palatal aponeurosis important is because it closes off the pharyngeal isthmus, preventing nasal regurgitation and swallowing. Here's another picture showing of the insertion of the levator palatini. I put this picture up is to give you an idea about the maxilla and the mandible. If you actually think of a grinding stone, the mandible is the part which is used to pulverize the food, and the maxilla is the base, the receiving part where the food is crushed against. Now we've dealt with the oral cavity and the oropharynx. We would go into the pharyngeal anatomy, which is the main topic of the day. So this is a picture of the whole of the sagittal view of the whole of the aerodigestive tract, and you can see the oral cavity, oropharynx, soft palate, and the vallicula and the larynx over here. Now we'll be talking about this whole portion now, the pharynx. I will not be talking about larynx because it has already been dealt with by a previous speaker. However, I will tell about the extrinsic muscles of the larynx, which are also a part of the infrahyoid musculature. So the infrahyoid muscles are the muscles which are attached to the inferior part of the hyoid. There are 4 in number: the sternohyoid, sternothyroid, omohyoid, and thyrohyoid. All of them are supplied by the ansa cervicalis from the cervical plexus, and only the thyrohyoid also has a nerve supply from the hypoglossal branch from the descending hypoglossi. The infrahyoid muscles help in depressing the hyoid bone and the larynx during speech and swallowing. It's more useful in speech as compared to swallowing. So here you can see the cadaveric anatomy of these infrahyoid musculature. This is the thyroid muscle, and then the sternothyroid muscle. which is inferior to that. And laterally, you have the omohyoid muscle, which goes down lateral to the neck. You can see these muscles without the other structures, the omohyoid muscle, the sternothyroid muscle, and deeper is the thyroid muscle. Now, position of pharynx in relation to the larynx and oral cavity. The pharynx extends from the skull base to the inferior border of the cricoid cartilage anteriorly, and also the inferior border of the C6 vertebrae posteriorly. The pharynx is basically a tubular structure and with muscular walls comprised of longitudinal muscles internally surrounded by circular layer of muscles. The external muscles consist of superior, middle, and inferior constrictor muscles. They are responsible for constriction of the walls of the pharynx. We can see here the superior, middle, and inferior constrictor muscles. And they contract involuntarily in a sequential manner from above downwards, and to propel the bolus through the pharynx and into the esophagus. So if you actually look at the pharynx, you can divide into three: the nasopharynx, oropharynx, and laryngopharynx. The nasopharynx is the part of the pharynx is posterior to the nasal cavity, not very much involved in swallowing, and this part is superior to the soft palate. The oropharynx extends from the soft palate to the hyoid bone, and the hypopharynx or laryngopharynx extends from the level of the hyoid bone down to the cricopharyngeus muscle. The posterior oropharyngeal wall, which is over here, it continues inferiorly as the posterior wall of the hypopharynx, and behind it, lies the lateropharyngeal space, as we spoke about. And there are two small gutters or reservoirs, triangular in shape. These are called the piriform sinus or piriform fossa. It is an anterolateral recess situated on either side of the hypopharynx, and they act as gutters during swallowing. So the food actually comes and splits into two lateral food channels, and then they go towards the upper esophageal sphincter, and they're directed via this straight away, and then they go into the cervical esophagus. And there is a region called the postcricoid area, and it is the anterior wall of the lower hypopharynx, and extends from the level of the cricoarytenoid joint to the edge of the cricoid cartilage. So this area posterior to the posterior to the lower posterior to the larynx is the cricoid area. So you can see again here in a cadaveric video the pharynx and the lower part of the pharynx. Once we isolate, you can see the pharynx as a tube, and the different musculature of the pharynx. The pharynx extends from the skull base down to the esophagus, and these are the muscles. Oh, sorry, I'll just go play the video again. I think somebody is trying to annotate the PowerPoint presentation, so it keeps coming in between. Sorry about that. Okay, so now if we actually divide the pharyngeal tube, you can see that you can divide into three parts: the inferior, middle, and the superior constrictor. We'll talk about each of these musculature. Coming to the superior constrictor, it originates from the pterygoid hamulus. Pterygoid hamulus, pterygomandibular raphe, and the posterior end of the mylohyoid line. So imagine like a semicircle. So from the tongue to the mylohyoid line, all the way to pterygomandibular raphe and to the pterygoid hamulus, you can see from the skull base, and it extends to join and insert posteriorly into the pharyngeal raphe here. And basically, it comes all this superior part is attached to the skull base of the occipital bone. It's supplied by the pharyngeal branch of vagus and the pharyngeal plexus. It also forms the lateral wall of the oropharynx, as I had mentioned. Middle constrictor, it originates from the styloid ligament and the greater and lesser horns of the hyoid, and it inserts. You can see this greater and the lesser horn of the hyoid. So it originates from here, and it inserts in the midline or posteriorly in the pharyngeal raphe. So you can see the hyoid bone over here, the prominence of the hyoid bone. This middle constrictor is also supplied by the pharyngeal branch of vagus and the pharyngeal plexus, and also a small part is by the branches of external and recurrent nerves. It helps in constricting the pharyngeal wall during swallowing. The inferior constrictor is the thickest of all the pharyngeal constrictors, and it consists of two parts, the thyropharyngeus and the cricopharyngeus part. The thyropharyngeus originates from the oblique line of the thyroid cartilage and the lateral aspect of the cricoid cartilage. You can see here, and also the thyroid ligament. It inserts posteriorly into the median pharyngeal raphe with their upper fibers ascending to overlap the middle constrictor. And the cricopharyngeus muscle, it is from one cricoid cartilage to other cricoid. It originates from one side of the cricoid cartilage to the other side, and it inserts posteriorly and encircles the pharyngoesophageal junction, and the same is for the opposite side. It's also supplied by the pharyngeal plexus, the branch of and the branches of the external recurrent nerves. It helps in the constriction of the pharynx and during swallowing. So these three constrictor muscles are the external circular layer. The other is the longitudinal muscles. They are internal layer, internal longitudinal thing. This is the salpingopharyngeus, the stylopharyngeus, and the palatopharyngeus muscles. These muscles help in shortening or widening the pharynx during swallowing, and also helps in sometimes in speaking. Now, coming to the esophagus, this is the muscular tube which begins at the continuation of the pharynx and the neck and ends at the junction within the stomach. Normally, the transition from the pharynx to the esophagus occurs at the lower border of the C6 vertebrae, that is the postcricoid area, and the esophagus descends anteriorly to the vertebral column through the middle mediastinum and traverses the diaphragmatic hiatus. After entering the abdomen, it joins the stomach along the lesser curvature, and this area is called the cardium. The length of this entire esophagus along the lesser curve, the length of the entire esophagus ranges from 19 to 25 centimeters in men and 18 to 22 centimeters in women. The main function of this esophagus is to transfer the bolus material from the pharynx into the stomach, and basically it's from C6 to T11 vertebra. Between the inferior constrictor and the esophagus, there is a small constriction, which is the narrowest point of the swallowing tract, and above that, between the fibers of the inferior constrictor, is a small triangular space called the Killian's dehiscence, and which is a site for a propulsion diverticulum or a Killian's diverticulum or a pharyngeal pouch. Now, there are in the esophagus, there are three constrictions which are normal constrictions, and it's the first constriction is at the level of the cricopharyngeal sphincter. It is about 15 centimeters from the upper incisors, and the second one is the constriction which is crossed by the aortic arch and the left main bronchus. It is at around 23 centimeters from the incisors. And the third constriction is when the esophagus pierces the diaphragm, which is about 40 centimeters from the incisors. These constrictions can be clearly seen when we're doing a video fluoroscopy or a modified barium swallow. And these are normal constrictions and should not be confused with any abnormality. The nerve supply of the esophagus is by the orbis plexus. This is the enteric nervous system, for the, and also the mesenteric plexus in the submucosal plane. So esophagus as such, if you see in a cross section, it's also of two layers: the outer longitudinal layer and the inner circular layer. The inner circular layer is supplied by the orbic plexus and the mesenteric plexus, and the extrinsic nervous system, or is supplies the longitudinal muscles. That is the parasympathetic supply from the vagus via acromial nerve, and the sympathetic supply from the thoracic spinal cord segments. So this is the extent of the thoracic esophagus as it goes from the C6 vertebra down to the T11 vertebra. That is the diaphragmatic hiatus, and it enters into the cardia of the stomach. Thank you.
Sir, thank you, sir, for the extensive coverage of the anatomy of pharynx. Of course, we are really happy that we have covered beyond the topic. So we'll take up a few questions
Sure.
from the audience. So any of the audience who wish to ask questions can unmute and interact with the speaker. So we usually have a lot of questions for clinical topics.
Yeah, anatomy topic is, unless it's something else, someone has a different view on the factual anatomy.
Yes. So one question from the chat section: can you please brief RPT constriction for muscle? Sir, Dr. Satyanarayan, sir, can you, what do you mean by RPT constriction, sir? Dr. Tejaswini, can you elaborate on sinus of Morgan?
Sir, I was just asking.
Hello.
The pharyngeal.
Do you see my screen? Or
sir, you have to share your screen.
Okay. No. What was the question? Pharyngeal piriform sinus, or I missed that part?
The pharyngeal constrictor, superior, middle, inferior. It was a nice portrayal of in the dissection. Can you just show it again?
Yeah, thanks.
Yeah.
Is that a question?
I want you to repeat the constrictors once again.
Oh, the constrictors. Okay. Someone was asking about sinus of Morgagni.
That was the second question.
Okay, now I got it. So I'll finish up that because I have a picture of that. But it is basically a space between the upper border of that constrictor muscle and the skull base. It's more towards that the nasopharynx and side. It doesn't more of related to nasopharyngeal carcinoma, tumor spread, those kind of things. Nothing at present related to swallowing, at least as far as I know of. But if someone wants to give them the input, I'm more than happy. I would contribute. Sorry, to swallowing anatomy. So I'll just share the screen regarding the pharyngeal constrictors again. Share screen. Okay. So I'll start from this point. Is that okay? So basically, if you see the whole pharynx, there are two parts. The
we don't see
external. Oh, okay. You don't see. Hold on a second. I'm sharing.
Hi. Thank you.
Is it? Can you see it now?
No, we are seeing your screen, but we're not seeing the cadaver specimen.
Yeah, I'm coming to that. Sorry. I thought I'm not seeing the screen. So this is, I'll just go here.
Yeah.
So if you actually see in this cadaver video, you can see that lower part of the pharynx where the constrictors will start. This may be the level where the C6 and hyoid bone would be the level where in middle and inferior constrictors meet. Higher up is the superior constrictor. So you can see this whole thing as a pharynx, as a tube. And you can see that superior constrictor starts from the skull base, from the base of the skull. A part of it is attached to the occiput, and the other part towards the oropharynx side. And this is the longitudinal muscles, the outer the muscles of the inner longitudinal layer. And I go to the next one. This you can see the constrictor divided into three halves. You start from bottom, inferior, middle, and the superior constrictor. And you can see each one is overlapped into the other. And this is the superior constrictor. Again, within the confines of the mandible, you can actually see the mandible, both the ramus of both mandible and the superior constrictor encasing and also forming a lateral wall of the oropharynx. On the sides, it forms a lateral wall. On the posterior part, it forms a posterior wall of the oropharynx. And this blends into the middle constrictor. And one more video of the superior constrictor, more close up. It condenses into the face and blends into the pharyngobasilar fascia towards the skull base.
Yeah.
And these are the attachment points where it originates. And that is the posterior attachment. And this is the middle constrictor. Middle constrictor is attached to the hyoid bone and the greater and the lesser horn of the head. So it encases the hyoid on either side, and you can see as the hyoid bone moves, the middle constrictor also moves. And posteriorly, it connects again to the pharyngeal raphe. This is a part of a tube. The anterior part is open. At this level, you'll see the tongue. I was explaining about tongue attached to hyoid bones. At this level, you will encounter the tongue anteriorly, base of tongue and larynx, superior part of the larynx. Coming to inferior constrictor, this is, as ENT surgeons, the most common question everybody asks during training is the Killian's dehiscence and the pharyngeal pouch. So the two parts, inferior constrictor, thyropharyngeus, cricopharyngeus, and the gap in between is the Killian's dehiscence. And the inferior constrictor is attached to the lateral wall of the thyroid and the cricoid cartilage, and then inserts into the pharyngeal raphe. A part of the posterior wall of the hypopharynx is the inferior constrictor.
Can you
then it blends down into esophagus.
Parapharyngeal and retropharyngeal spaces?
But I unfortunately don't have that video of the parapharyngeal space, but I can do that as a separate anatomy and thing later on, because there's quite a lot if you're thinking about a robotic surgery anatomy for oropharynx later on.
Audience, we have one more lecture by Sir on anatomy of pharynx in relation to robotics.
Okay. So maybe at a later date, and so I will show that. And so are they happy with these three videos? These are the ones. And the last video is the esophagus. That is the thoracic esophagus. This is when after the heart and the bronchi are removed, and you can see this is how the esophagus would go in the middle mediastinum. And this is the esophageal hiatus. So we will see all this in video fluoroscopy or modified barium swallow when we are assessing the patient for swallowing. Okay, thanks.
So we have a lecture on physiology of swallowing by Dr. Vidhyadharan sir on Monday, which is 31st May. Of course, I'll be sharing the links again on WhatsApp and Facebook groups. Sir, one more question is about pyriform fossa.
Okay. Pyriform fossa, anything in particular? That it is a triangular space lateral to the larynx on either side, and it's like an inverted pyramid. Sorry, I'll get the thing up. And basically, the apex is in continuity with the as you go down to the apex, you go towards the upper esophageal sphincter. This is the narrowest portion there. And anything in particular regarding piriform phase, piriform fossa?
Oh no, sir. The question was just, and can you please explain piriform fossa?
So in the pictures, it's very difficult to explain it in a two-dimensional thing. But the best view you can get is through a laryngoscopy and the patient saying a deep E, and you can see the whole piriform fossa open up. And I can share a FEAS video on during the physiology part, and I can show you the piriform fossa right at that time. But we keep in mind it's an inverted pyramid on either side, and they have the reservoirs where the food gets caught. For ENT surgeons, it's a very common place for a foreign body getting stuck there also, because below that is the below and medial to that is the most narrowest part, which is the upper esophageal sphincter.
Next,
I hope that.
Dr. Yuvraj. So most of the time I'm getting difficulty in Ryle's tube insertion. Whenever I'm opening the mouth by using index finger, if I push epiglottis anterior, can I insert Ryle's tube?
If I push anterior means pulling the epiglottis towards. If we push the epiglottis posterior, if you're having difficulty inserting the Ryle's tube beyond the nose, you're saying it goes down the nose, but at the level of where it enters into the larynx, the most simplest way is to get the patient to swallow while you push. Or other thing is to ask the patient to lie flat in maybe a left lateral position or something, and then try to use gravity to push towards the thing, because the narrowest point is this post-cricoid area. And it also depends on what size of the tube. Maybe sometimes you might have to change the Ryle's tube. So pushing the epiglottis down, that may make the patient gag. That's the only thing.
Next question by Dr. Samir. Why do foreign bodies like coins get lodged only in Pharynx in children?
I think you answered. It's the narrowest part. So just at the that is the most narrowest portion, because anteriorly you have the cricoid cartilage and posteriorly you have the vertebral body. You can see the bony landmarks, and in between that's such a small slit-like space, and that is surrounded by the cricopharyngeus muscle, which is always in constriction. So that it is good that sometimes foreign body gets lodged there and not lower down in the esophagus. So it's easy for you to reach out and take it out. Only thing, sometimes they can fall into the larynx if you're not too careful. So that's the narrowest point.
So yeah, any more questions from the audience? We will wind up for the day.
So thank you so much. I hope anatomy was. I'm trying to make anatomy as interesting, but it's very good to have good knowledge of anatomy for anything as a medical doctor or a speech and language pathologist, especially for swallowing. You'll understand better. Thank you very much.
Yes, sir. So thank you very much, sir. Before closing the session, just two announcements I would like to make. The previous class on pedicle flaps in head and neck was stopped in between because of cyclone which we had in the west coast of India last week. So we are rescheduling it for tomorrow. So I request all the PGs to please be part of this program. And also we'll be having physiology of swallowing by Dr. Vidhyadharan sir, and I'm sure sir is a master of swallowing therapies and is well known for his research work in this field. So I request everyone to be part of this wonderful session, which is going to be on Monday, 7:30 p.m. Sir, thank you, sir. Once again, you have been really
thank you so much
us for all these sessions. Yeah, I'm really grateful for your support. And we'll see you again on Monday. Thank you, sir.
Hopefully, we will just an hour before we just work on the mic. Yes. I'll just try to work on it and see if it works. So we won't delay the session.
Thank you, sir.
All right. Thanks a lot. Take care. Good night.